podium, sir. Meanwhile, you start, Dr. Malleswari.
Yes, sir. Good afternoon, sir. Good afternoon, all of you.
Nupur is absent.
Oh, it's not moving. So, hypertensive maculopathy is one of the complication of trabeculectomy, and timely management can avoid the vision-threatening complications. And I am presenting here 2 cases which were managed differently. And finally, the patients came with good vision and the better control of intraocular pressure. This 26-year-old male patient, who is a physical trainer, came with angle decision glaucoma, and he underwent trabeculectomy for the uncontrolled pressures. And after trabeculectomy, 2 weeks after that, the pressure was again high. So my colleague did laser suture lysis. After that, the pressure suddenly came down to 0, and there was a decreased vision, and vision dropped down from 618 to 4/60. Cornea was clear, AC was well formed, but there is a disc edema, so which was shown here, and the macular folds also there, and the macular thickness was increased 377 microns. So when I saw through the conjunctiva, there was a raised flap where the apical suture was raised. So I went inside, and then I tried to suture the scleral flap with 10 sutures, and then I want to reinforce the bleb area with the scleral patch graft. 2 weeks after that, the bleb is well formed, and the pressure raised to 12 millimeters of mercury, vision improved to 612, but there was an exposure of the scleral patch graft. So again, I did mobilization of the conjunctiva and AMG graft. So this was the 2 weeks picture where the patch was very well covered, but this is the fundus picture where there is an increased disc edema on the macular folds. Again, the vision dropped down to CF 1 meter. So I searched for the literature, and then I thought of doing autologous blood injection, where 0.5 cc of autologous blood is taken from the cubital vein and then injected into the bleb area, which was seeped into AC also. 3 weeks after that, this is the pre-injection picture, and these are the serial OCTs where you can see the improvement. And this is the final picture where the disc margins were clear and the macular edema reduced, and the patient got vision of 6/9 with the control pressure 22 without any anti-glaucoma medication. And here is the second patient. This patient, actually Jonine open angle glaucoma patient, he underwent trabeculectomy. I only did the surgery, but he lost follow-up for 15 days and stopped steroids after 5 days of surgery. And the vision was 5/60. He was denying any history of trauma, but pressure was 6 millimeters of mercury. I was soft, but AC was well formed. So I thought of managing medically with the oral and topical steroids, but after 2 weeks also the ILM folds were remaining. So this was the picture where I can see the scleral flap tightly opposed to the sclera with the apical suture. So I thought of, okay, I can manage it with injection because AC is well formed. So initially I first thought of doing autologous injection, but didn't work in this patient. So I went inside, and again I did the scleral flap suturing and reinforced with the scleral patch graft. And finally, this is the outcome. So these are the serial OCTs from the April 24 to February 25, where there is a gross improvement in the macular area. And finally, the patient got the vision of 6/9 and the pressures around 12 millimeters of mercury. And the ocular integrity can be achieved in similar cases, but with the different modalities. And a timely shift in the management options can salvage the vision of the patients. Thank you. Jai Jai Shankar, Har Har Shankar. Thank you, sir.
Your first case, your OCT showed a lot of ORCs, that is in the outer retinal corrugations.
Sir.
Clearly an indication of RPE, disease. I mean, so we can expect that the macular edema will not resolve by itself for a long time. So, in your first case. In the second case, please.
So actually we took the opinion of retina also, sir. But they were telling, because the pressure is low, if the macular folds and the disc edema will be there in hypotensive maculopathy, but it is very rare condition. Once the pressure is improved, then it may improve the condition. Because in the first, after suture lysis, it came to me, and then I did resuturing. Pressure increased to 12 millimeters of mercury, vision improved to 612. Even before, just after the surgery, it was 618 because of the cycloplegics, but it got improved to 612. But again, because the scleral patch graft is exposed, I just want to cover it because of the fear of blebitis. So after 2 weeks, again the patient came with the severe disc edema and the maculophores, and the vision came down to CF 1 meter. So young patient, 26-year-old patient, male patient, physical trainer, I was worried. So I don't want to take him to war again. So I just thought of search the literature and just thought of giving a try with the injection, autologous blood injection. Exactly, the procedure is the simple one only. So it went inside and the fibroblast will cause fibrosis. Where it went, how it caused fibrosis, I don't know exactly. But finally the outcome is the patient vision, he got back 6/9 and the pressure is 22 because the discharges are not much and the vision is regained. I was happy. So for the second patient, I thought of, because I did the surgery, I know that scleral flap was well opposed. So I thought of giving a try with the injection first, but it didn't work in that patient. So I went inside and just sutured the flap again and reinforced with the patch graft. And after that, he developed a cataract and removed the cataract. And now last month, I did 1 month follow-up of cataract surgery. His vision is 6/9 and there is a lot of change in the macular area. And so I thought these two cases are different.
Yeah,
And
I think you're right that
Thanks.
sometimes you have to do multiple procedures. One procedure may not be effective for every